Essentials of Health Information Management, Principles and Practices, 2nd edition, Chapter 1, Healthcare Delivery Systems. So in this presentation, based on Chapter 1, our objectives are to summarize the history of medicine and the delivery of healthcare in the United States, list programs and services offered as part of the continuum of care, differentiate between for-profit and not-for-profit healthcare facility ownership, interpret the authority and responsibility associated with a healthcare facility's organizational structure, define and provide examples of licensure, regulation, and accreditation. So in your textbook, they lay out the history that we have in medicine by looking at studying the different remains and other reliable sources. We can piece together how medicine got started and evolutionized to the way we recognize it today. Your book breaks it down into 5 periods that they can categorize in some reasonable fashion. In your book, or in Table 1.1, it starts off with us looking at prehistoric medicine and ancient medicine. And what it tells you here is that during that time, the basic premise was that they believed in those spirits and supernatural things were the cause for diseases or different things that occurred in the body in which they could not explain. They attributed that to supernatural instances. Also, during that prehistoric time, they may have used plants to relieve pain. And then we move forward into ancient medicine. A couple of things occurred here, and again, we're looking at Table 1.1. The first known physician was Imhotep, and Imhotep actually authored an ancient manuscript where he described more than 90 anatomical terms and 48 injuries. So it's some type of like an A&P book or miracle book, one of the first. Also during the ancient medicine time, we have Hippocrates, right? He's a Greek physician. He was the first physician to consider medicine as being a science and an art versus religious and supernatural thought. You also will recognize Hippocrates when we talk about the Hippocratic Oath, using his or bearing his name. That was adopted in ancient medicine times. You also had Greek philosophers during that time. They felt like any illness and diseases that occurred were due to an imbalance in the 4 elements of earth, air, water, and fire. Your Roman physician Galen during the ancient times, he excised tumors in infected bone and resectioned ribs and sternum. And as a result, he gained some understanding as to how the body is anatomically put together. You have the Greek physician Antilos, who became the authority on aneurysms. He was also able to provide surgical direction in the treatment of cataracts, fistulae, and bronchi and intestines. You have back in Bible times and ancient times with Israelites. If any of you all have had opportunity to look at the Bible, we noticed that they had different rules on prohibiting public contamination of wells and the type of food that they ate, which may carry diseases. So they were prohibited from those things. Also, during this time, isolation from people who had contagious diseases. You had the ancient Chinese who believed in yin yin and yang, right? And so diseases came about when these two forces were not in balance. You also had Chinese acupuncture during this time. In ancient India, they practiced medicine known as Ayurveda. And that stressed the prevention of and treatment of illnesses. They also had Indian surgeons who performed successful amputations and plastic surgery. Now in Table 1-2, we move from the prehistoric and the ancient medicine to medieval medicine. And so what are some of the important milestones during medieval medicine? Well, Razi, which is a Persian-born physician, he was the first to give accurate descriptions of measles and smallpox. You got Avicenna, an Arab physician, who authored what we call the Canon of Medicine. And basically, he summarized medical knowledge within that canon. You had epidemics that occurred during the medieval time, leprosy and the Black Plague. The first hospitals were created in Baghdad, Cairo, and Damascus. The first medical schools also popped up here in the medieval time in Italy. From there, we go from medieval to Renaissance, and you may be familiar with Renaissance if you have taken humanities. They talk about Renaissance period, a period of enlightenment. In Table 1-3, we're looking at Renaissance medicine. Ambrose Pare, he ended in that time the use of burning oil to cleanse wounds. He also taught the use of ligatures in amputation. During this time, the Renaissance period, you had your first scientific studies that went on in regards to the human body. You had autopsies, observations that occurred. You have Andreas Vesalius, who was an anatomist, and he wrote what we call Dehumanized Corpus Fabrica, which illustrated bones, muscles, blood vessels, nerves, and internal organs. Syphilis was also an epidemic during the Renaissance period. Girolamo Fracastoro, he was the first to identify syphilis. And he also wrote about how the spread of infection is due to invisible germs in that book called De Contagion. So he was to enlighten ones on how the transmission of diseases was occurring through these various invisible germs. In Table 1-4, last but not least, is our modern medicine. So that we're moving up into a little more familiar territory. So what has happened in modern medicine? William Harvey, he learned about lymph abnormalities and how that contributed to cancer, which was the foundation to them starting to learn how to use surgical removal for cancer. Anton van Leeuwenhoek, he used microscopes to study organisms, and he learned about bacteria. You have an English physician, Edward Jenner. He learned about what we now call vaccinations. So how to make people immune to those smallpox, and really in terms of vaccination. And so this is the start of the study of immunology. You got Louis Pasteur and Robert Koch. They started the microbial or germ theory for disease. And so what they proved was that there are certain microbes that cause disease, and that killing certain microbes will stop that disease. Koch also invented a method for determining which bacteria causes diseases. So he found sources which which types of these cause certain diseases in people. By the end of the 1800s, we had learned about many types of bacteria and what diseases they caused. In the 1840s, Americans Crawford Long and William T.C. Morton, they brought about anesthesia during surgery. The scientific study called pathology was developed in the 1800s. We also had, before the mid-1800s, as a matter of fact, in 1865, where they really started emphasizing and learning about sterilizing surgical wounds. And they also end up learning during that time, instead of trying to get rid of the germs on a wound, preventing the germs from ever getting there during surgery. That's a technique known as aseptic surgery. X-rays were discovered by Wilhelm Röntgen in 1895. The discovery of radium by Pierre and Marie Curie, which was a powerful weapon used against cancer. Around 1910, you had the German physician and chemist Paul Ehrlich, who introduced chemotherapy. You have a bacteriologist, Sir Alexander Fleming, who discovered penicillin. Howard Florey isolated that penicillin. So that was our first antibiotic. In 1935, Gerhard Domich had the development of sulfur drugs to treat diseases in humans. Between 1940 and 1961, prothrombin, electrolyte, blood gases, creatinine, phosphokinase were also introduced. In 1955, polio vaccine was licensed. During 1960 through 1970, the World Health Organization, you may see that written WHO, had a vaccination program where they pretty much eliminated smallpox. In the 1970s, there were improvements that came about for cardiac bypass and joint replacement surgery, using CT scans. MRIs came about in the 1980s. And then in 1981, that's where your AIDS and your HIV came on the scene. They were identified. In 1985, they created a blood test for detection of HIV. In 1990, we had the Human Genome Project, where they looked at the human genetic material and they were trying to determine the different sequences of DNA. And then they published that human genome sequencing in 2000. And then finally in 1994, the scientists discovered genes responsible for many cases of hereditary colon cancer, inherited breast cancer, and the common kidney types of kidney cancer. So basically, we just did a quick review of the history of medicine in those different periods: prehistoric, ancient, medieval, Renaissance, and modern. Okay? Now, that's like international, across the world. But if we just focus down to the United States, there has been an evolution of healthcare delivery within our country as well. In the United States, in 1751, our first hospital was in Pennsylvania. And this is table 1-5 that we're looking at. In 1765, we had our first medical school, University of Pennsylvania. In 1847, the AMA came about. That's your American Medical Association. I'm not going to hit all of these. I'm just going to hit some very major milestones. So we got our AMA in 1847. And you know your AMA provides those standards for medical education. They also have those licensing boards that became about in 1800 through your AMA. The Bureau of Chemistry was in 1862 through our President Lincoln, which was the forerunner to the FDA, the Food and Drug Administration. In 1897, AOA, American Osteopathic Association, which is actually one of our accrediting agencies, they came about, was founded by osteopathic physicians. In 1898, we got the Association of Hospital Superintendents, which was the forefather or the forerunner to the American Hospital Association, your AHA. So that's an association for all your different hospitals and healthcare networks. In 1906, the Food and Drug Act, the first of those, was passed. So they now felt it important that we monitor our foods and medicines to make sure that they are safe. In 1910, through the Carnegie Foundation, we had what we call the Flexner Report, posed by Abraham Flexner. And what he brought out was that only one of the 155 medical schools that were in the United States and Canada had acceptable medical education. So you know this was contributing to us really standardizing the education that those physicians were receiving. And so that's the Flexner Report. In 1913, the American College of Surgeons, ACS, they came up on the scene, and they were interested in improving the quality of care for surgery patients. And they're going to do that by establishing standards. In 1917, the American College of Surgeons, they came up with the minimum standards for hospitals. And as part of their hospital standardization program, they had on-site inspections. All of this trying to standardize the hospital's processes and improving the care. In 1929, you had your first Blue Cross plan. So back then, Blue Cross Blue Shield did not exist. You had a Blue Cross plan and a Blue Shield plan. The Blue Cross plan came first in 1929. It was offered at Baylor University to school teachers. So they were able to get hospital care for $6 a year, 21 days of it. In 1935, this is when Congress passed the Social Security Act, right? Unemployment insurance, old age assistance, and so forth, but then at this point did not include disability or medical benefits as a part of your Social Security. So that's your Social Security Act of 1935. Your first Blue Shield plan came in 1939. So you had your Blue Cross in 1929, your Blue Shield in 1939. Your Blue Cross was basically usually cover your hospital care, and then your Blue Shield cover your physician services. But the first plan was offered in California in 1939. In 1946, we had the Communicable Disease Center, which was called CDC, and it's the forerunner to our Centers for Disease Control. If you know, they have the same acronym. Also there in 1946, you had the Hill-Burton Act, also called the Hospital Survey and Construction Act. And what they did was provide federal grants for hospitals so that they can update their hospitals using those federal funds. And in return for being able to do that, they provided reduced charge medical services for people who weren't able to pay for their health care. In 1951, you had Joint Commission that came about. They were originally called Joint Commission on Accreditation of Hospitals, but now we just call them Joint Commission. 1952, you have the Hospital Standardization Program being transferred from American College of Surgeons to Joint Commission. And this is where Joint Commission began to accredit hospitals. In 1961, you had the Conference on Aging for the White House. And they made recommendations, including Medicare, Medicaid, and Social Security reform at that time. The Community Health Service and Facilities Act of 1961, that was there for improving nursing home services and home care services. You have in 1962 the Migrant Health Act, where they were providing support and medical services to migrant workers. In 1964, you got your Surgeon General report on smoking. This is where we really came out saying that smoking causes cancer. In 1965, you had amendments to that Social Security Act that we were talking about back in 1935, and we were saying it didn't include certain things. Where in 1965, that Social Security Amendment came in. You had Medicare, which is Title 18, and Medicaid, Title 19, was brought on board as part of that Social Security. We also found through here, via Congress, Joint Commission was granted Dean status. And when a person has Dean status, what this means is the Center for Medicaid and Medicare Services, Medicare and Medicaid Services, or CMS, once a person is accredited through Joint Commission, they will also say that they have satisfied conditions of participation. And CMS is the ones that those standards within conditions of participation is via CMS. So you actually kill two birds with one stone. Once you are accredited through Joint Commission, you have also satisfied your requirement for CMS's conditions of participation. We had escalation in healthcare costs in 1970s, and for a lot of different reasons. We had a lot of expenses, and then we had technology and inflation and all these things kind of working together, and as a result, we had escalation in healthcare costs. 1972, there was another Social Security amendment where they looked at strengthening the utilization review process by using what we call PSROs, Professional Standards Review Organizations. And they look at quality and appropriateness of the services that's being provided, and they look at outcomes of those services. In 1974, you have the Privacy Act that was implemented, where they looked at protecting privacy for the individual within federal government hospitals and access to records. But though that was for federal hospitals, so non-federal hospitals didn't fall in that Privacy Act of 1974. In 1977, you had the Healthcare Financing Administration. We call it HICPA. And they changed their name to what we know now, CMS. And it was created separately from your Social Security Administration. In 1979, you had your Department of Education Organization Act became law. It was under Health and Human Services. In 1982, you have your Peer Review Improvement Act of 1982 that replaced those PSROs, those Professional Standards Review Organizations, and they changed those to what we call Peer Review Organizations, or PROs. And they were statewide utilization quality control organizations. You have your Tax Equity and Fiscal Responsibility Act of 1982, or we call it TEFRA. And this is where our first PPS system came about, and prospective payment system. That's a type of insurance payment system in which the physician and the providers are paid before services are rendered versus after. 1985, we have the Consolidated Omnibus Budget Reconciliation Act, or COBRA. And so we usually call it COBRA. People who are working may be familiar with COBRA. And that was in 1985. And so what happens is, if you are a former employee, you retire, your spouse, domestic partner, eligible dependent children, if you lose that coverage, you would be able to temporarily continue that coverage at group rates under COBRA. Your Emergency Medical Treatment and Labor Act, EMTLA. And what that did was establish discharge and transfer criteria for your Medicare and Medicaid patients. In 1986, you have the Omnibus Budget Reconciliation Act of 86. They require those peer review organizations to have to report cases that were substandard. Also, on your Federal Healthcare Quality Improvement Act of 1986, this is where your National Practitioner Data Bank was established. And this is where the providers and facilities will report physicians who engage in unprofessional behaviors. And they also check the NPDB when they're doing credentialing processes for physicians, or basically, in other words, saying when they are trying to be able to see patients at their hospital. The Nursing Home Reform Act, that's 1987. Making sure quality care was happening in nursing homes. In 1988, you had the McKinney Act that provided health care for the homeless. In 1989, OBRA created the Agency for Healthcare Policy and Research, and we now call that AHRQ, Agency for Healthcare Research and Quality. They do health service research for Health and Human Services, and they develop outcome measures and quality, and they look at quality of healthcare services. 1990, they required the peer review organizations to report adverse actions to state medical boards and licensing agencies. Also in 1990, you got your Patient Self-Determination Act. This is where they focused on making sure patients had informed consent and had the appropriate information that they needed to make healthcare decisions. You had your different documents, advanced directives under that Patient Self-Determination Act. That would be like your Do Not Resuscitate Order, your Living Will, those types of things, your Durable Power of Attorney. Those are all advanced directives under your Patient Self-Determination Act. In 1991, you had your Work Group on Electronic Data Interchange, WEDI. They implemented these electronic data interchanges on a national basis when transmitting insurance claims. Also, WEDI assisted in HIPAA being passed in 1996, the Health Insurance Portability and Accountability Act. Vaccination program for children was in 1993, and in 1995, the Social Security Administration was able to stand on its own. It was not in association with other agencies. It became an independent agency. And like we just mentioned, your HIPAA came about or was passed in 1996, where they looked at privacy, security, and transaction standards in electronic capacity for those covered entities. In addition, you had the Healthcare Integrity and Protection Data Bank that where they reported fraud and abuse in the healthcare system. It sort of overlapped that National Practitioner Data Bank with some of the things that was reported. You got SHIP, State Children's Health Insurance Program, in 1997 was established for health insurance for infants, children, and teens. In 1999, we have the Ticket to Work and Work Incentives Improvement Act of 1999. Americans with Disabilities, that's what it was helping. They were able to go back to work, and they didn't have to worry about losing their Medicare and Medicaid. In 2001, this is where HCFA, Healthcare Finance and Administration, changed the name to Centers for Medicare and Medicaid Services. In 2002, your peer review organizations became quality improvement organizations. So they perform quality control and utilization review of healthcare services. In 2003, your Medicare Prescription Drug Improvement and Modernization Act of 2003 came about, looking at Medicare recipients receiving prescription drugs. 2005, your Deficit Reduction Act, where they created the Medicaid Integrity Program that also looked at fraud and abuse. You have your Patient Safety and Quality Improvement Act in 2005 as well. It was a Title IX of the Public Health Service Act. And what they did in that act is to let organizations report different healthcare mistakes that occur in a safe environment, so that they kind of shielded them from civil and criminal proceedings, and they made those reports confidential. In 2006, you had your Tax Relief and Healthcare Act and they implemented the Physician Quality Reporting Initiative, PQRI. You'll hear about that. So the providers were given financial incentives for voluntarily participating in a quality reporting program. 2008, you have your Genetic Information Non-Discrimination Act that prohibited health plans from denying people coverage based solely on a genetic predisposition. And then finally in 2009, you had ARA, the American Recovery and Reinvestment Act, HITAC Act, Title 16 of the American Recovery and Reinvestment Act. They basically provided financial incentives for the eligible providers to implement health information systems and EHRs. All right, so I did take time out to go over all of your Table 1.5 to look at where we started to where we are now. You will revisit a lot of these in legal, especially all those federal initiatives and laws that were passed and those types of things. So this would be a very good review. Now moving on, let's talk a little bit about the continuum of care. When we mention that, and you will hear that a lot in the health information management field, we are talking about when a patient is receiving a full range of services. So whatever the patient needs across the continuum, across the board, whether it be acute care, nursing homes, physicians, anything that they need, a specialist, all of these come together to provide the services that that patient needs. This is a continuum of care. A patient has ongoing needs, and we make sure that those are taken care of at the appropriate level of service. Now, on that continuum of care, you have what we call primary care, secondary care, tertiary care, and quaternary care. When we're looking at primary care, that's your point of first contact. This is usually going to occur in an office setting, and it's usually continuous and comprehensive. Examples is like with your primary care provider. They provide primary care. That's the first person you usually go see. Some of the services will be included under primary care will be like immunization, family planning. Now your secondary care is the care that's provided by medical specialists. So you may see this when you go to your primary care doctor and they refer you to a specialist, then that will be secondary care. Now tertiary care are specialized hospitals usually that provide services, like a trauma surgery center, a burn treatment center. Those are what we would call tertiary services. Specialized hospitals, or they provide different types of services that aren't in general, that's not generally offered in regular hospitals. Your quaternary care is a subset of your tertiary care. It looks at advanced levels of medicine that's highly specialized and usually very costly. Like experimental medicine will fall under quaternary care. When we look at health care facilities, they are owned by different individuals or entities, and they can be not-for-profit or for-profit. And basically, when you're looking at for-profit and not-for-profit, we really are discussing what do they do with their excess income. If it's a for-profit facility, then when they have excess income, they're going to give that to their shareholders and owners of that facility. If they are not for profit, when they have excess income, they reinvest it back into the facility. So that's the difference between for-profit and not-for-profit. And you have different types of hospitals, and they can be not-for-profit or for-profit. You have government-type hospitals. Usually the government hospitals are going to be not-for-profit. And usually they are ran using taxes from people. The Veterans Administration Veterans Affairs, VA is an example. Proprietary hospitals, they are usually owned by corporations or private foundations, and they are for profit. You have voluntary hospitals. They are not for profit, and usually you're going to see them like religious groups owning those types of places, or other voluntary groups like the Shriners Hospital would be an example. Teaching hospitals, they're usually affiliated with a medical school, and they could be for-profit or not-for-profit. And usually when you have a teaching hospital, they are training sites for medical students, or what we call residents. You see them there in those type of hospitals. Now, looking a little bit closer at the healthcare facility, the structure of a healthcare facility, if you review Figure 1.1 on page 15 in your textbook, you see that there's a governing board, there's administration, you got medical staff, and then you have other departments within that hospital that fall under different categories or divisions. Now, when you look at the governing board, it's at the very top. And a lot of times in different organizations, this is what you're going to see, that top down, where the responsibility and authority is at the top and then it flows down. Your governing board is the one that sort of oversees the whole ship. And the people who are on the governing board are usually members from the community of where that hospital resides. It has the ultimate legal authority for how that hospital is being operated. Another important thing about the governing board is that they hire the administrator, the CEO of the hospital. He's hired by the governing board. Your hospital administration, I call those, or you may hear it being called your executive suite. This includes your CEO, your CFO, where your CEO is your chief executive officer. That's the top position, not looking at your governing board, nor your medical staff. Your chief financial officer, that's for your financial or your accounting and billing and payroll. You got your chief information officer, and a lot of times you'll see your IT department and your health information management department falling under your chief information officer these days. And you got your chief operating officer, your COO, overseeing specific departments and ancillary services. Now your medical staff, that's your physicians, your nurse practitioners, your physician assistants. They are considered to be your medical staff. A lot of times your medical staff are not actually employees of the hospital. They use the hospital's resources to see patients, but they are not really employees of the hospital. And then, and thus so, your CEO is not really the boss of your physicians. A lot of times what you will see is if there are issues with your physicians, they're going to send it to your chief medical staff person, a chief medical staff physician. But so those are going to be your licensed doctors and nurse practitioners and physician assistants that are included in the medical staff. And that's why you see that dotted line on your hospital organization chart in Figure 1.1. They have a special type of relationship. You're going to see that your medical staff is organized into different clinical departments. Table 1.7 gives you a lot of your different medical specialties for your doctors and physicians and so forth, like dermatology, gynecology, urology. You should be familiar with those. Anybody who's been around in the healthcare system, and we're all consumers of it. Then you also have your different staff committees that and medical staff committees that they serve on for your medical staff. You have what we call house officers. And if you recall, I was just saying that most of your physicians are on that medical staff are not employees of the hospital, but you can end up having physicians who are employees of the facility, and they call those house officers. Now, when a physician wishes to see patients in a particular hospital, then what they do is they go through a credentialing process where they put in applications for clinical privileges, and then that application is evaluated. They look at their education, their experience, what type of medicine they perform, their character. This is where that National Practitioner Database is going to come into play, where they're going to review to see if they have any adverse actions. Also, that Healthcare Integrity and Protection Database that we talked about, they're going to check all of that with this particular doctor. Drug Enforcement Agency license, all of these things will be looked at. And because before these things were implemented into law, a physician could probably go to one state and do something that they had no business doing, and go to another state, and because we didn't have these types of data banks, the other state would never know anything about it. But with these things in place, it's hard for a physician to do that. So then your Medical Staff Credentials Committee is going to review the application and put forth recommendations. Your Medical Staff Department Chairperson is going to review their application. Your Executive Committee is going to review their application and provide recommendations. Then your medical staff is going to vote on it, and your governing board will be the last to vote on the application as to whether that physician is approved or rejected in terms of having clinical privileges at that hospital. There are several categories that the medical staff can be in. They can be active, and that means they actively bringing in patients and so forth. You got an associate category, meaning that physician is being considered to the active category. You got consulting physicians. They come in when they're needed. You have courtesy status, where they occasionally admit patients, but not on a regular basis. And then you got honorary. Maybe someone has retired and they have an emeritus status. All right. Now, one thing about the medical staff, they're going to create bylaws and rules and regulations in which the medical services are applicable or are in compliance with. And we already talked about the credentialing process. So that's like what is covered under the medical staff. Now, we did mention different, if you look at Table 1.8, you can look at those medical staff committees that I was naming off, like the Executive Committee, Act on Reports and Recommends from Medical Staff Committee. So these are those committees involved in their credentialing process. If you look at page 18, Table 1.8. But as a part of this, we mentioned the committees and so forth, and these different hospital departments. All of these things work together to provide these services that we provide to patients. The hospital departments, if you look at Table 1.9, you see the different departments you'll find in a hospital, like your admissions. And this is where the patient first is registered to come into the hospital. They also get all the administrative documentation, your consent, your release of information. We talked about the advance directives under that Patient Self-Determination Act. These are collected here during the registration from your registration department or your admissions department. You got case management, and I'm not going to hit all of these. I'm just going to go through a few. Case management is concerned with the discharge plan. So they take that patient through the discharge plan process, where they're trying to identify any needs that patient has once they are discharged, any post-hospital services that they need. They also work with the family and the patient about the discharge plan and those types of things. You got you're familiar with your emergency room. That's another department. Your Health Information Management Department, that's what we are currently studying about. And you know our main thing there, we maintain records. We want to make sure that those records are accessible. You got human resources, we're familiar with that. And when you come in, like say working for a hospital, you go through an orientation program, they work with the patient, the employee's benefit, and those types of things, and as well as employment. You got your nursing department, you should be familiar with that. You also have patient advocacy. They, when patients have different concerns, or they want to commend someone or anything of that nature, patient advocacy is involved. You got your performance improvement, or they may call that the quality department. They are concerned with quality and appropriateness of care. So they monitoring different processes, making sure we're upholding different standards, like for joint commission or anything like that hospital is involved in. They're making sure that we're doing just that. You got pharmacy, and we know they deal with the medications that the patients are being administered. You have purchasing department. They get all the equipment and other products and stuff that we need in order to provide the healthcare services. So risk management is another one. They are concerned with minimizing risk, being proactive about risk situations, making sure that does not occur as much as possible. They try to control those things. They deal with or work with what we call the incident report. This is an internal document when things occur or mishaps, and they fill that out, and that is directed to the risk management department. They also work with the insurance companies and the attorneys. Utilization management department, they work hand in hand with your case managers. They're looking at, they review all the levels of care that's occurring and making sure that those things are appropriate based on the diagnosis of the patient. And they also determine what's the appropriate length of stay for that patient in the hospital. Now, also, you have your general hospital committees in Table 110 on page 22. And you can look at those health information. There's a health information committee where they're making sure appropriate documentation is being done. And the other one, you got a forms committee, because the medical record is made of multiple forms, and the forms need to be structured appropriately. You don't want to have duplication of forms, and the forms need to be able to capture the desired information. And then you also have the Infection Control Committee. That's the other one I like to talk about, where they look at those nosocomial infections, infections that occur in the hospital, so they want to prevent those from occurring. So you have that Infection Control Committee. So the hospital runs using various committees to look at specific things, and with these committees, they have meetings. You got to have meetings for these departments and these committees, and our goal is to have successful meetings. And so several things have to occur if we want to have a successful meeting. First of all, they have to work as a team. It needs to be well structured in order to have a successful meeting, and they have to be organized. There needs to be a person chairing that committee to make sure that they establish an agenda. And usually that agenda, they work with the secretary on that committee to pull that agenda together. You also have to have committee members who are going to actively participate in that committee for us to get something done. And you can have formal or informal committee. It just depends on what the goals of that committee is. Now, with the agenda, you want to have all your items of business on that agenda, what we're going to cover today. Your typical agenda, you'll have something about review of meetings, review of minutes from the last time. You have old business, new business. You have member reports, and then you have other business. And you also have when that next meeting is going to be and where. Also, during your committee meetings, you're going to have your secretary taking minutes, right? So everything that goes on in that meeting, they're going to record it in the minutes. And it's just a summary, so they don't write every little thing. So with the minutes, what are some of the things you're seeing commonly in the minutes? Your date, place, and time for that meeting, who was present, who was absent, any guests, what items were discussed, what actions did we vote on, when the meeting was adjourned, and when the location, time, and date of your next meeting, and then you're going to have a signature of your secretary. Also, what will make those minutes more effective and efficient is when that person is recording those minutes. When someone does something or acts on something, they need to identify them by their full name in the minutes. And you want minutes done as soon as possible. Say the secretary just records the meeting and they take the and then they prepare the minutes after it. You want to do that as soon as possible. And once those minutes have been approved, then the chairperson needs to sign off on those minutes. Now, your health information department in your hospital, what are they concerned with? Well, they're concerned with access, appropriate access to that patient information in the medical records. And confidentiality is also important. So there are several different departments that commonly fall under the health information department or fall in their purview. It could be variations depending on where you go, but in general, these are the functions and departments you will see. You have your administration, and usually can be, your administration for your HIM department. They're usually RHIEs or RHITs. Registered Health Information Administrator, that's an RHIA credential. Registered Health Information Technician, RHIT credential. The 2-year program is an RHIT credential, which is the program we are in now. Cancer registries a lot of times fall under your health information department. Tallahassee Memorial's cancer registry is under the purview of the health information department. In the cancer registry, you have what we call registrars, and they can be have a credential that's called a CTR, Certified Tumor Registrars. And basically what they are concerned with is cancer. They monitor and follow up patients that have cancer. They also send reports and different data and information to the appropriate agencies that are concerned with cancer statistics and other entities. They send generate reports for. They also are involved in being on committee meetings. A lot of your committees are multidisciplinary, so you will see your cancer registrars also participating in that meeting, providing statistics on the cancer program, and they also are involved in professional associations. Now, coding and abstracting is another function, falls under the Health Information Department purview. Coding is nothing but assigning numeric and alphanumeric codes to the different diagnoses and procedures and services that are provided to that patient. You have your CPT, your current procedure terminology coding. That's basically for procedures on an outpatient basis. Then you have your ICD-9-CM that's going to eventually turn into ICD-10. We call these our diagnosis codes. Your CPT is known as your procedure code. You have your HCPCS, your healthcare procedure coding system. This is another type of coding system that deals with the different, what do you call it, supplies and things like that. So like your crutches and stuff like that, wheelchairs, they will be coded to a HCPCS code. So you got several different little systems here, and they take those, and those are some type of number or alphanumeric code, and they're going to attach them to each service. It's a code for each service or possible service or diagnosis or procedure that occurs for everyone. In order to assign those codes, they have to abstract that documentation to support that code. So this is what goes on in coding and abstracting. Image processing, this is another function, and especially it's very prevalent at this point with everyone, with a lot of people or a lot of organizations transitioning to the electronic health record. So they convert their paper records to the EHR, and so you have a lot of your image processing going on. One thing that's important with this record, whether it's paper-based or electronic health record, the information is granted on a need-to-know basis. So even if you are an employee, you cannot just access records just because you're an employee. We are still interested in that you are acting accessing that record because it's actually needed. And we don't give you any more, any less than what's needed for the job that you're doing. You also will see the pulling of records for when people need to access records. We also have employees sign confidentiality statements because of the nature of that information. Make sure they understand passwords and security measures and all those types of things. You also have the function of the incomplete record processing under the Health Information Department. This is where your assembly and analysis of discharged patient records occur. Basically, when we talk about assembly analysis, when the patient is discharged, so they have an active record on the nursing station, on the floor, we call it. Then they're discharged. Then it becomes under the purview of the Health Information Department. Those are either delivered to the department or we go pick those up after that patient is discharged. One of the first things that occur, we assemble the discharge record. So it was an active record, now it's a discharge record. So you may see departments in which they have a discharge assembly order. If you look at figure 1.3, here's a sample of a discharge patient record assembly order. And all that is how we're going to organize those documents in that record upon discharge. Now, you may see some that are different from when it was an active record, but you may have facilities where when the patient is discharged, you maintain the same organization of the documents as they were when they were active. We call that a universal chart order. Another thing you may hear mentioned is reverse chronological date order. All this means is however that record is organized in whatever section, the most recent document is on top and the oldest is on the bottom. That's reverse chronological order. It's usually easier for providers and physicians and the different people who work with that patient record to access the information, because the most active information is usually your most recent information, and it's right there on top. You want a nurse or someone getting ready to document, they just have to go to the top page or whatever section they're looking for, because that's reverse chronological order, so it saves a lot of time. So once we have the record assembled, then analysis occurs. Analysis is when we're looking for what we call deficiencies. Deficiencies are things that are required in the record but is not. Signatures on specific documents, or forms missing, anything that is required that's not there, that is a deficiency. And the record becomes incomplete if they have deficiencies. And so what they do is once they analyze their record, identify all the deficiencies if they have them, then they're going to file that record in what we call the incomplete record room, or whatever, incomplete room, or whatever they call it. And this is where the appropriate staff who needs to make that record complete, maybe it's a physician's signature that's missing, that physician or who have you comes in and provides that signature so that we can now reanalyze that. And then if there's no more deficiencies, the record is complete. So a lot of times with that going on, you're going to have requests for records. Maybe that physician has 5 records that he needs to complete. So he will request the records, or they may have a system or a records request form that they fill out to get records that's needed, or however they do that. But that's what happens in incomplete record processing. Medical transcription is usually under your Health Information Department. This is where they transcribe dictated reports. When we talk about dictated reports like discharge summary. So they transcribe them and create some imprinted reports, and then we're able to put that into the medical record. If it's in an electronic health record state, then when it's transcribed, there's a it electronically routes over into the EHR, so you're not necessarily printing anything out, but still a transcription function is occurring, and then an electronic signature is provided on those documents. Now, when we talk about electronic signatures, They got different ways of doing that, but we're basically talking about authenticating a document. You have what we call a digital signature that uses public key cryptography. And basically, when we talk about public key cryptography, it attaches an alphanumeric number to that document that's going to be unique to the person who's signing it, as well as that document that they signed. And then they bring in with that your user login and your password, and you might even have a smart card or a biometrical type situation. Well, a smart card has a little gold, little colored contact area. If you look on Figure 1.4 on page 28, you know what I'm saying? So when you slide that in, the information is on that little area, so you can process that to identify who you are. If they use biometrics, basic bio is like life, is looking at physical characteristics of a person. So that's like your eye scan, fingerprints, and things like that, in order to determine that you are who you say you are, or you are the person who's actually signing that document. So then once all that is verified, that person can go in and put their electronically sign that document, and it date and time stamps that, and we can use that as an electronic signature. Now when we talk about record circulation, this is the way that record is going around the entire hospital. It circulates around to those people who need the record. So they may request that record, either they call into the Health Information Management Department, or they submit a record request to retrieve those records. Are we signing out? We may use out guides and things like that, because our job is to make sure that the records are accessible. And so this is what we mean by record circulation. We'll probably have a tracking system so that we know where that record is at all times, no matter where it is in the hospital. Now, release of information processing. People request their information. Other parties request that information, but of course, we have to make sure we have appropriate authorization in order to release that information. So that falls under our purview as well. And requests can come from anywhere: attorneys, physicians, patients, and so forth. Even CMS. Now we also, you may see where we contract out different services. And so we also have to be careful and pay attention to different vendors who we may contract services out to, because they still fall under the different compliance factors in terms of confidentiality, security, and privacy. A lot of times you may see you contracting out different functions because those people will do it better and it's more cost effective. So it's really a quality improvement concern why we may decide to contract out different functions. Now, licensure, regulation, and accreditation is very important. When we talk about licensure, we're looking at license. In order to operate a business, you have to have license, and there are certain standards that you have to meet and comply with in terms of state laws, local laws, and regulations that you have to follow in order to be able to maintain a license. So anybody can't go up and I'm just going to open up a hospital. So there's certain things that you have to comply with in order to have a license to operate. Now, when we talk about regulations, regulations is an interpretation of a law that's written by a agency. One example is CMS's conditions of participation that we talked about. Your federal and state laws, they come from legislative bodies, and then these laws are implemented as regulations. So like Medicare and Medicaid, they fall under federal regulations. All right? You got state laws that regulate insurance companies. All right? Now, you may have, I don't know if you have, but it's called the Code of Federal Regulations, CFR. It's a codification of the general and permanent rules that we go by, and you will find those in what we call the Federal Register. It publishes those and all those rules and regulations from the different departments and agencies in federal government. And so you can go to that Federal Register and look up particular things. For example, when we decide to move to the ICD-10 from ICD-9, that would have been found in the Federal Register. They update these every year, and your Federal Register, it comes out on a quarterly basis. It's basically a legal newspaper. And so these are where we can go and get up to speed on different things coming down the pipe. Now, accreditation, this is voluntary. And so organizations voluntarily comply with accreditation standards. And when they are accredited, they are saying to the community and everyone around them that I have gone above and beyond what is required by regular law or licensures or regulations. We're going above and beyond that. And so we follow and comply with these standards. And then that accreditation organization comes in and they do a survey. It could be on-site or off-site surveys. And those surveys are for them to determine whether you are in actuality complying with those standards that are put forth to you. Your note there in your book brought out a very good way of thinking about regulations and accreditation. Regulations are required and accreditation is voluntary. Now, there are many different accrediting organizations. Table 112 on page 30 and 31 lists out several of those that you can look at. I'm going to just look at one or two. I need you to review these. Your Commission on Accreditation or Rehabilitation Facility, that's CARF. And so they deal with accreditation for rehab facilities, similar like what Joint Commission does for hospitals. You also have, look at another one, your Accreditation Association for Ambulatory Healthcare, AAAHC, and just as the name suggests, it looks at ambulatory healthcare facilities. I'm going to skip Joint Commission for just a second and look at, you have the National Commission on Correctional Healthcare. And basically they look at correctional facilities and accreditation for those type of facilities. So they do have health care related departments in a correctional facility. The National Committee for Quality Assurance, basically they look at quality of managed care plans. And they use what we call a HIM tool in order to collect that information about the quality of care by those managed care plans. Now, looking back at Joint Commission, this is your most popular one, and like it mentioned here, was formerly known as Joint Commission on Accreditation. We used to call it JCO, but we now call it Joint Commission. Now, with Joint Commission, we mentioned before that they had deemed status, and we know that means if you are accredited by Joint Commission, you also have satisfied your CMS conditions of participation. Now, some other things about Joint Commission, they have what we call an ORIX initiative, and this is where they're going to integrate these quality measures into that accreditation process. Joint Commission and CMS work together to standardize common measures that they call National Hospital Quality Measures. So they have National Hospital Quality Measures that they use. There's also the Shared Visions New Pathways Initiative, where they change the way they score the accreditation process. They basically score elements of performance in order to determine that whether they're compliant with those standards. The other thing about Joint Commission, they have a continuous ongoing survey process. They also provide the candidates for Joint Commission are those who are accredited with what we call a periodic performance review tool, and they can take that tool and use that internally and do a self-evaluation on themselves to make sure that they are compliant with those standards so that they'll be ready for their on-site survey. They use what we call a tracer methodology, where they take the patient record and allow that patient record to guide them through that their accreditation process. The National Patient Safety Goals, you'll hear about that through Joint Commission. They do unannounced surveys where they're looking at making sure there's high quality patient care being realized. They also have the different facilities participate in voluntarily reporting sentinel events. Sentinel events are those that are going to occur in death or end in death. So this is sort of like a review slide here, looking at some of that recent legislation that we had talked about, that Deficit Reduction Act. I think we talked about that more so in the beginning when we looked at the evolution of healthcare in the United States. That was the act in 2005, and what they did was create that Medicare Integrity Program that dealt with fraud and abuse. That Patient Safety and Quality Improvement Act in 2005, it was a Title IX of that Public Health Service Act. They will encourage people, they encourage the facilities or the organizations to report their mistakes without fear of civil and criminal proceedings. So that's what that had to do with. Now, the Tax Relief and Healthcare Act of 2006, they implemented that Physician Quality Reporting Initiative, where they gave those physicians financial incentives to voluntarily report into a quality program. Your Genetic Information Non-Discrimination Act, it prohibited those health plans from denying coverage based solely on genetic predisposition. And then finally, your American Recovery and Reinvestment Act, in which HITECH Act is a part of it. They provide financial incentives for your electronic health records. These are your most recent legislations. Those were the last ones we talked about with that evolution of healthcare. And the final slide were some relevant key terms that we talked about in this presentation, that being the continuum of care. And we realize that that is the whole gamut of levels of care services that are provided to a patient. So we're making sure that patient gets what they need at the appropriate level, and that's a continuum of care, whether it be ambulatory or outpatient, inpatient, hospital, specialty care, nursing home, whatever that is needed. That's your continuum of care, making sure that patient gets what they need at the appropriate level. We talked about licensure, regulation, accreditation standards. We just recently wrapped that up. And what we want to remember about that, licensure is basically that license to operate. And then your regulations is an interpretation of law that's written by the regulatory agency. And then you have your accreditation, which is a voluntary process where you strive above and beyond what's actually required by law. And we use standards for that organization to strive for and to reach in order to know that they are above and beyond the standards required by law. So the standards are basically measurements, right? They are ways of measuring where we are, where we stand. That will conclude our presentation. I'll see you next time.